for the seminar on systemic racism and pandemic response, racial inequities in COVID-19. So we will have Ruqaiijah Yearby as a presenter. Ruqaiijah is a full professor, member of the Center for Health Law Studies at St. Louis University School of Law. She's also co-founder and executive director of St. Louis University's Institute for Healing Justice and Equity. She authored various issues that are directly relevant for the debate today, among others, protecting workers that provide essential services. And she also co-authored a paper which is on racism, is a public health crisis, here's how to respond. So using empirical data, her research explores the ways in which discrimination prevents vulnerable populations from attaining equal access to quality healthcare, resulting in health inequities. Ruqaiijah earned a Bachelor of Science in Honors Biology from the University of Michigan, has an MPH from Johns Hopkins School of Law, and a JD from Georgetown University Law Center. I will introduce, after her presentation, Emily Simmons, and so I will, you'll wait for that. Emily will give a commentary, bringing some of the debate further, particularly focusing on the Indigenous populations in Canada. So without further ado, Ruqaiijah.
Thank you. So thank you for having me. I'm so excited to begin this discussion. And so this talk is based in part on the article I think you read, which I co-authored with Professor Seeman entitled Systemic Racism, the Government's Pandemic Response, and Racial Inequities in COVID-19. Today, I'm going to expand that discussion just to bring in a little bit more about housing, which we have talked about in other articles, and to also talk about the application of mask mandates. So when I talk about racism, people have various different definitions. This I am pulling from work I've done with Professor Mohapatra, as well as the work of David Williams, right? Systemic racism, particularly as we view it in the US, refers to a complex array of social structures, interpersonal interactions, and beliefs by which the dominant group categorizes people based on their value and deservedness, and it's used to disempower and devalue other groups. This actually can apply across borders, right? We think about this in colonialism as well. And it's really about power and does not require bad intent, as we like to say is the cornerstone of our discrimination law. So when we think about racism, particularly in COVID-19 inequities, I just want to again highlight some things that go beyond the article, really focusing on the application of mask mandates, as well as the lack of access to clean water. And so here's one good example of mask mandates. There was a requirement for masks in Nashville, Tennessee, but the only people they tended to arrest were people of color or homeless people. And so you can see based on just the pictures, the differences, and again, examples of systemic racism. Lots of people standing by a sign, mask required, not wearing masks. We do not want to enforce it against them. One, not just because we view them as valuable, allowing them to have the choices to mask or not, but also related to money because they're tourists and we want tourists in this area versus the individual who was arrested. We can also see this play out, as I mentioned, in terms of lack of access to clean water, which is so important during COVID-19, but just generally. And so here you see in the US that we oftentimes think about that it impacts those in rural areas the most, but it does not. It impacts people of color, particularly American Indian and Alaska Native. live, and they are supposed to be provided clean water from the US government. That is one of their responsibilities. But because the US government has been quite neglectful in that, an estimated 1 in 10 Native Americans lack access to safe tap water or basic sanitation, without which a host of health conditions, including COVID-19, diabetes, gastrointestinal diseases are more likely. And that's true in the urban areas as well, for predominantly Black and Latino neighborhoods. The last slide I want to show just on this in the United States is to highlight, again, this was featured in a prior article that Professor Moapasha and I wrote, looking at, on the left, the zip codes in St. Louis that were racially segregated were the same ones that had higher rates of severe health-related housing violations, meaning they didn't have access to clean water, toilets, kitchen, and those were the same zip codes that had higher rates of COVID-19 cases and infections. And as I talk about later on in the presentation, they also lacked access to testing sites for COVID-19 and treatment. So this is all connected. Here, I tried to pull out some information really focused on Canada, looking at where we see coronavirus and people identifying as Black. And so as you can see, again, this correlation between or association between higher rates of COVID-19 in communities that are predominantly Black. And this is because of racism that is not about bad intent, but that structures access to water, employment in a way that leaves people more susceptible to infections and poor health like COVID-19. So let me get into my roadmap and really pulling in some of the work that was in the article, but I have updated some of it because things continue to change. And so I'm going to talk about racism in the pandemic response, the model that was in the article, racism in employment and healthcare, and provide some additional readings. So when we worked on the paper, a lot of people asked us why we didn't just focus on class. And one of the reasons we didn't just focus on class was because of the fact that COVID-19 was racialized quite early. And this is nothing new, because as we've seen in the 2009 H1N1 pandemic and other pandemics, the virus is often labeled or connected with an outgroup that is usually a racial and ethnic minority. In 2009, it was with people coming from Mexico, and we've seen this labeled as a Chinese disease. And I always highlight Missouri because I live here and thus can only offend me and not others, and how poorly we have done. But you can see the Missouri Attorney General sued China for harm related to COVID-19, but stood by while meat and poultry processing plants or nursing homes in the state were associated with the majority of the infections. And in fact, the Attorney General is now suing schools who want to actually do mask mandates or anything to track the stop of spread of COVID-19, but very racialized, right, in terms of the blame. The same in Texas, that after the governor removed all mask mandates and other things to mitigate the spread of COVID-19, there was an increase in the spread of COVID-19. One wonders, right? But instead of going back to some of the public health things that had stopped the spread of disease, why not go ahead and blame people coming in from Mexico? The same thing sort of happened in Ohio, even though a little bit different, where a Ohio state senator who was also a physician asked whether Blacks and the colored population don't wash their hands as well as other groups or wear masks or do not socially distance themselves. And that's perhaps why they had higher rates of COVID-19. And I'm using his exact language. He was fired from his physician job, but appointed the chair of the Ohio State Health Committee by his cousin after making those comments. So very racialized when we think about it. And this is just another example in Florida, just to ensure that you understand it's not just Missouri, but again, right, of blaming workers, farm workers who are an integral part of our society of America, while allowing, again, integral part, but college students who are coming down for spring break to not mask. And then there's an increase, of course, in variants, but who gets blamed, right? It again is racialized and put on workers who are migrating from different areas, including Mexico. And so one of the things we wanted to highlight was the way that systemic racism has been a part of the government pandemic response, not just because of the things that government officials have said, including the former head of Health and Human Services, who again blamed the outbreaks in meat and poultry processing plant on the culture of workers instead of the lack of safety, health and safety standards adopted, but also because of the legal response that was seen in the US. And I am going to try to bring in some of the discussion with what has happened in Canada as well. We decided to focus on employment and healthcare, understanding, as I started off this presentation, that it also impacts, it also flows from housing and other laws as well, and how this connects to racial inequities and COVID-19 infection and death. And again, although we are focusing on racial inequities, we understand that it's a broader problem, right? And so it's not just racism, it's also about classism, which goes to socioeconomic status. There's an intersection when we think about women of color and other groups, particularly people with disabilities. But we wanted to highlight it from the perspective of racism and then step back as other scholars who have written in those areas could be able to talk about the problems with other groups. So as I mentioned, systemic racism, very broad. Today, I am going to focus on structural racism. And what structural racism is the ways that laws, policies, practices are used to structure systems to advantage the dominant group and disadvantage minority groups. It also includes the ways that organizations work together to create separate and independent barriers through the neutral denial of equal treatment. And so it does not require bad intent, which I think we often get caught up in wanting to see when we think about racism or some form of discrimination. So one of the ways that we argued that we could move past this was to begin to adopt the health justice framework and really to bring in the health justice movement. It is built in part on the environmental justice movements, reproductive justice movements, and other social justice movements, including the civil rights movement, that centers communities in taking the lead in developing the solutions and calling for government support, both financial and social. And so the first one is really about trying to address systemic racism, calling for structural remediation that requires policymakers to take into consideration the past and the present harms of racism when they are trying to address something such as a pandemic. Second, the interventions mandating healthy behaviors must be accompanied by supports, particularly financial supports, and I'll talk about this more when I talk about employment, and that racial and ethnic minority communities must be empowered and engaged as leaders in driving this change so that the change that is made actually helps them and understands their lived experience. And so you can see here, again, this is in the paper, just where each of these prongs fits into. And so now I want to move into a discussion just about racism and employment. Now, in the paper, I primarily focus on meat and poultry processing workers, but in other things, I have focused on some of the other workers in healthcare, as well as in agriculture. And so in the US, about 30% of essential workers worked in healthcare, 21% in food and agricultural industry. A majority of these workers are racial and ethnic minorities or undocumented immigrants. And research showed that working in these industries was strongly associated with a higher risk of contracting COVID-19 and dying, which makes sense because even when we went under some lockdown or stay-at-home orders, these workers continued to go out and interact with people and usually did not have access to masks or the things to make them to help them stay healthy. Blacks disproportionately occupied the top 9 occupations that placed them at higher risk for contracting COVID-19 and potentially infecting their homes. And we have to keep that in consideration, particularly as we see the government's response, particularly in the US, disregarding workplace infection, failure to enforce healthy and safety laws to protect these essential workers. And so it should not be surprising to us that some of the outcomes are racial inequities in COVID-19 infections and deaths. And just to make clear, this is not the only risk factor, right, in terms of employment being the only risk factor for increasing people's risk of infection. As I mentioned, it's also housing and other things. But one of the key points that we have seen is that a lot of infections of workers, we have seen that being associated with workplace and then spreading throughout their entire communities. And so this is one example of the outbreaks that happened. And this was in Waterloo, Iowa, which is in Black Hawk County. Tied to the Tyson meat processing plant, which is alleged to have required workers to work long hours and cramped conditions, transferring people from facilities shut down for COVID-19 outbreaks, failed to provide appropriate personal protective equipment, masks, sufficient social distancing or safety measures. And in fact, the state of Iowa twice declined assistance from the Centers for Disease Control and Prevention. They were going to help them with this COVID-19 outbreak, but Iowa said no. And in fact, sort of delayed the response because they stopped reporting the information about the numbers of outbreaks to even people in that county. One of the things I also want to highlight is that while the plant was bad in terms of not providing appropriate social distancing, Tyson managers and supervisors also had a betting pool on which worker would test positive for COVID-19. Many people argue, and I'll get to the executive order a little bit later, that they didn't have to close. So many other plants claim they didn't have to close because of an executive order. But one of the things that was part of their arguments for staying open was the fact that they were going to lose so much money. And as you see here, which is the same case in the case I'm going to talk about regarding Canada, that was not actually the case. They have been making record profits from being able to stay open. And they could have implemented some of the social distancing practices and protective practices and still made money. but protected people's lives. One of the reasons they were allowed to stay open is because under President Trump, there was an executive order issued. So President Trump issued an executive order to keep them open, and it included draft language that came from meat trade associations saying that meat will become scarce if they closed. But any good legal person or critical thinking person would assume that if you're worried about the scarcity of meat in the US and you're going to keep open plants, that then you would limit the ability of these companies to export the meat. That was not the case. So it's kind of illogical to say we're worried about scarcity of meat, let's keep the plants open in the US, but then export a record number of meat outside of the US. Then you're not really worried about scarcity, you're really worried again about profit. After the issuance of the executive order, we see a governmental agency at the federal level begin to pressure the CDC as they're investigating an outbreak in South Dakota. And you see this after the executive order of the federal government trying to pressure states to allow these facilities to stay open, even as people continue to get sick and to die. And so 1 month after the order, the number of COVID infections had more than tripled, and the number of deaths had more than quadrupled at meat and poultry processing plants. And a majority of those cases, when we had disaggregated data, showed that it disproportionately harmed racial and ethnic minorities, and not just the workers, but also the communities in which they lived and across the United States. So 6 to 8% of all US COVID cases were tied to meat and poultry processing plants. Having a plant in the county was associated with a 51 to 75% increase in cases and a 37 to 50% increase in deaths. And these are the lower estimates. If the facility was closed for 3 to 4 weeks, then you actually saw that the COVID-19 infection rates were less than counties that did not have meat and poultry processing plants. You could see this same problem with some of the cases in healthcare, particularly in nursing homes. But part of the problem in our response, the government's pandemic response in the US, is that they allowed companies not to report the infections of their workers. So we do not know the true percentages of COVID cases in nursing home workers or healthcare workers prior to the change in the administration. I did want to highlight some of how this has impacted Canada as well. We see that this is the same problem in the meat packing plants in Canada. And in fact, one of the things that the US failed to do was respond to an outbreak that they were alerted to in Canada early in the pandemic, and understanding about how it could spread throughout meat and poultry processing plants. This I pulled from an article which was good about workers actually euthanizing and getting more money in response to this horrible outbreak that happened. But I did want to highlight that one of the places that had the highest rates of infection was this meat packing plant, and that you still had it disproportionately harming racial and ethnic minorities, the Filipino community, and that at the time, the workers were not protected and not alerted to the fact that cases were rampant. It was only after workers died that the plant was closed and they began to address it. And at this point, at least from the article, again, the company made record profits. benefits. And so what do we need to do? So part of these issues, and I haven't talked about it as much in this presentation, is to allow people paid sick leave and to prohibit punitive attendance policies. And so in the US, when we passed some of the laws about COVID-19 economic relief and standards about people staying at home, we did not take care to ensure that it applied to essential workers. And so essential workers were told, oh, you can still go to work if you are sick. They weren't necessarily provided with paid sick leave because most of the meat and poultry processing plants were not covered under the economic relief bills, and they were not required to stop docking people and firing people if they decided to stay home because they were sick. Most people probably still would have gone to work because they are not making a living wage. And so that's the point about hazard pay and continue a guaranteed basic income. If we want people to adopt healthy behaviors, we have to provide the financial support that they need. And then the Institute Employee Safety Boards. This was adopted by the Los Angeles County Board, which created this employee safety boards, because even though they were trying to protect people, they still found that meat and poultry processing plants had a lot of violations. I'm going to jump now in my remaining time to talk about healthcare. This is the section that Professor Mohapatra wrote, but I've also written about this area. But definitely in the article, I wanted to raise up that this is her work that she highlighted, right? And so in healthcare, we see the same issue of racism, lack of tracking, impact, steering resources to hospitals and facilities in predominantly white neighborhoods. And that has been associated with increased rates of infections and deaths in the racial and ethnic communities. In Michigan, just to give an example, they didn't really begin to track race or expand testing until late April 2020. And by that time, a lot of racial and ethnic minorities were impacted, majority definitely higher infections and deaths than their percentage of the population. In a Black city in Gary, Indiana, they began tracking it. They finally got a mobile testing site to this area. But after 2 weeks, they moved the mobile site to another area that was predominantly white. And in Canada, there was the same problem of initially not tracking infections and deaths based on race and ethnicity. And there's still being some gaps once the disparities were identified of actually getting the resources to the people who needed it. And so I just want to highlight sort of how this discourse is going about, right? We see in a big sign most recently, some neo-Nazis targeting anti-racist doctors who actually did research and tried to get the hospital to provide the same level of care to Blacks and Latinos who their research showed were not being provided with the same level of care as whites. According to the neo-Nazis, they feel like that Black and Latino patients are receiving care that they are not qualified for, which I don't really understand how you are not qualified for life-saving care if you are suffering from that condition, but that's their argument. And they claim it's a blatant anti-white policy fueled by the same thing as critical race theory. But what I want to highlight are the news stories that we have seen throughout COVID-19, which really don't even track all that has happened about people of color being turned away, right? And so in Detroit, my hometown, where you see a woman who was a healthcare worker who was turned away 4 times from the hospital that she worked at from receiving a test. We see in North Carolina, Latino Latinos sick with COVID-19 are sent home from hospitals, even though they were sick enough to be receiving care. And the same thing with the Black doctor in Indiana who was turned away from care. And these are just some of the stories. There are stories about in Indiana, how they turned people away, Latinos away from care, from testing. We see here at Michigan, again, the denial of care, even when it's clear that white Michigan residents are getting more care than people of color. And so one day after a report came out showing that white Michigan residents were getting COVID vaccines at twice the rate of African Americans, some senators put forth a bill that would not allow the state to consider the disproportionate impact and access to care that racial and ethnic minorities were getting, as well as the poor, even though they knew whites were already getting more care than those people. And we can see this throughout, again, in Missouri and Dallas, that our governor continued to send vaccine doses, not to the communities that needed it the most, like Kansas City and St. Louis that were predominantly Black, but to send them to areas, rural areas with people who voted for him, and the wasting of doses. It got so bad that he actually had to explicitly say that he was going to send doses to address the racial disparities because he had mismanaged it so bad. We see this in Dallas, where officials were trying to hold back doses early in the provision of vaccines because people were traveling to predominantly Black and Latino neighborhoods and taking the doses from the individuals there. So they were trying to hold back the doses, but were threatened by the state that if they did not give doses to people outside of those communities, they would not receive any doses. Why is this important? Because we see examples of racial disparities in terms of who gets access to the tests, to the treatments. Nobody has faced a lawsuit, but as soon as there is an adoption of a policy, of an index, or a tool that is trying to get rid of those disparities, that we see lawsuits being brought by whites who are not suffering any harm. And so this is an example. You have in New York, instances of people being turned away from care, of being turned away from vaccines, of people turned away from what they need. And so New York City and New York State adopted an index which would take into consideration these disparities. And immediately a Cornell law professor sued. And it's not just here. Minnesota and Utah were going to adopt protocols that allowed doctors to consider race among 15 other factors in qualifying for certain COVID-19 treatments, because we see that these people are the most impacted. And because of lawsuits and because of pressure, they have decided not to adopt these protocols. But when you look at their COVID numbers, you can see racial and ethnic minorities are disproportionately harmed. In fact, Native Hawaiian and Pacific Islanders have about a 3 times higher infection rate than whites in Minnesota, and they will not be able to get the access to the treatment they need. And so what do we need? We need to track data based on race and ethnicity, and we need to address the systemic racism. If we have resources, the best way to try to address or get out of the pandemic is not to give those resources to the people who don't need them, is to give it to the people who are most impacted. And so with that, I am going to stop. These are some of the additional readings, articles that I have written, and I look forward to your questions.
Thank you very much for this incredible overview of the issues related to the pandemic response and racism. So we're now I'll now invite Emily Simmons to provide a commentary. Emily is a PhD candidate in Science and Technology Studies at York University. She's a researcher at the Center for Wise Practices in Indigenous Health at Women's College. Emily is a Métis researcher working at the intersection of critical anthropology and Indigenous science and technology studies. Her research interests include anti-colonial research design and the politics of evidence related to the planning, programming, and evaluation of health research and health systems. She is an alum of the Civic Laboratory for Environmental Action Research, the Technoscience Research Unit, and the Digital Research Ethics Collaboratory, as well as a contributor to the Technoscience Salon and the Politics of Evidence Working Group. So Emily, up to you.
Thanks so much. Let me just see. Can you guys see my screen? Is it sharing? Never great with these things. So thank you so much, Professor Yearby, for your generative work and talk. I also want to thank the conveners for inviting me to speak today, as well as all of you who have taken time out of your busy schedule. So just to begin, I'm going to situate myself a little bit more, and then I'm going to sort of give you an overview of what I want to touch on today, as well as the structure of the flow of the conversation. So as was mentioned in the introduction, my name's Emily Simmons, and I'm a white-coated Métis researcher of mixed ancestry. So on my mom's side, I'm Red River Métis. My relations are Umpervilles, Turners, and Woodmans. And then on my father's side, I'm settler from London, England. I'm trained as an anthropologist, which means that I'm sort of invested in stories and how we start to talk about each other and think about each other. And I am currently a member of the Indigenous Center for Wise Practices in Indigenous Health, which is a multidisciplinary team that's focused on advancing the health and wellness of Indigenous people across Turtle Island. First, I want to sort of provide a little bit of context about some of the conditions that result in widespread anti-Indigenous racism and racism more broadly at the structural level, and how this sort of played out was amplified by responses to COVID-19. Building very much on Professor Yearby's work, here I'm going to talk about structural racism using the definition that she sort of offered us at the beginning. Throughout the conversation, I'm going to use the term Indigenous, but I want to be very clear what I mean here. When I say Indigenous, I'm talking specifically about First Nations, Inuit, and Métis people in Canada. And I'm also sort of offering reflections based on my experience, which is around programming and service design in an urban context for Indigenous people. So really, my experience is drawn from the GTA. So I'm familiar with the communities that are here, as well as those that are traveling into the city to access care. So I think the distinction matters. We have to be really considerate when we are talking about Indigenous health, because the experiences in urban settings can be quite different than rural settings, as well as across our respective nations. They can look quite different. And we need to be really cautious and particular, as actually means to interrupt reductive characterizations of Indigenous people as homogenous communities. So next, after sort of walking you through the landscape, I actually want to focus on an example of a COVID-19 response that celebrates the ingenuity of Indigenous community-led responses here in Toronto. I think this is critical as well, just to show actually what an environmental or a health justice perspective can look like in action and what it produces. So that is sort of the structure of my flow today. And to conclude, I want to outline some key principles that I think are essential for implementation of what would be seen as a health justice framework in the Canadian context for Indigenous people, as well as offer some resources. So I'm not sure if my screen's sharing or not. Let's see. Let me try this one more time. Thanks for your patience.
It was sharing, but you simply have to do the slideshow.
There we go. Thanks. You would think like a year into, 2 years into a pandemic that I would have mastered the technology, but that does not seem to be the case. So thanks so much. So I want to be really clear here that my reflections are grounded in three presuppositions, and they move off of these suppositions. So first, as Dr. Yearby so clearly points out in her work, in her talk, that race is not a social determinant of health. This point very much builds on the idea that race itself is not a determining factor of health. Rather, the determining factors are the socioeconomic conditions that racialized peoples find themselves subjected to and subject of. I point this out because we need to keep in top of mind when we talk about information or health data collected on race. Perhaps what's more accurate is to understand that this data is a reflection of the very real material conditions the construction of race has on people. So we're not talking about race as a determinant, we're talking about the conditions of racialized people that impact health. And this is really key. When we talk about data or we use data to talk, what I'm saying here is that we are talking about lived experiences. We are referring to people's sacred life worlds, storied experiences with systems, some of which, and I'll get to this in the Canadian context, were historically designed to oppress or even eradicate entire communities or nations of people. My second point is that in the Canadian context, health and social inequalities are rooted to colonial policies. The current conditions that shape the uneven health effects and adverse impacts of pandemics like COVID-19 within Canada are direct results of colonial policies, which are underscored and driven by particular concepts of racial inferiority. In other words, colonial policies shape the conditions that form the lived experiences of racism. And here you're going to start to see actually these patterns do cut across borders. So the lived experiences of racism, they do so in forms of disproportionate exposures to environmental toxins, medical violence, access to reliable housing, safe, clean water, food, just to name a few. To give you a sense of what this looks like in terms of scale, in 2021, there were 43 water advisories still in place in 31 different, mostly northern, mostly on reserve communities, predominantly in Ontario, but also in Manitoba and Saskatchewan. Okay, so when you're dealing with an infectious disease and you have no access to clean water, we know what that's going to do in terms of outbreak. My third point here is universal healthcare is an important health system model. However, uneven infrastructure and resourcing are major gaps in its implementation. When you have persistent gaps in infrastructure and the uneven allocation of resources, such as access to clean water, universal healthcare can't be implemented in the ways that it's often described in the social imaginary and in public discourse. As a value-based model, so an aspiration, it's critical, like it gives us a place to strive to. But in practice, it remains a healthcare system that is constantly reworked, renegotiated at the point of care by many Indigenous people and people of color. As Professor Yearby's work highlights, the access to safe care is there, but labor practices don't support and protect workers seeking care, receiving treatment to therapeutic supports is disincentivized. So we saw this very much that, well, if there was an option or a resource there, the punitive measures of missing work disincentivized people from getting that care. So for so many in Canada, the concept of our collapsing healthcare system, which was again a dominant discourse that we heard emerged as a result of COVID-19, felt very frightening. I want to be clear that yes, right now we're currently looking at a lot of labor shortages, but my point here is that for many others, Black, Indigenized, and racialized folks, the healthcare system has failed and been riddled with gaps. So we want to be careful about, think critically about what that discourse is when we say universal health. So I just want to give you a little bit of context next for the origins of actually what systemic racism looks like in Canada. So within Canada, many legal scholars, many people, the Canadian government attribute the roots to structural racism to the colonial system. So, and settler colonialism in particular. So it's here that this relationship gets set up between the state as well as Indigenous people. An overview of racist policies that have been implemented in Canada begins probably most logically with this account of the introduction of the Indian Act. In the 500 years since contact with Europeans, First Nations people, Inuit, and Métis communities have been subject to overtly racist assimilation policies, as well as settler colonial policies, which differentiate a little bit from colonial policies in that they seek to not only exploit Indigenous land, but participate in the erasure of Indigenous people from that land. I also want to be clear here to extend this, that legalized racism has also been perpetuated against several groups of people in Canada. So, for example, although Canadians, I think, have a very romantic notion that the role in aiding runaway slaves, Black Canadians have also been subject to racist policies since their arrival in Canada. I want to talk a little bit about next. So now that we understand where the sort of origins and the roots of the structural racism in Canada is, let's look at what sort of some of the impact is. So we know, right, several reports have come out about the impacts, both in health, wellness, intergenerational, that settler colonialism and anti-Indigenous racism has had in Canada. So, you know, these are reports that are prior to COVID-19. So in 2005, we see the Truth and Reconciliation Commission report very deliberately and plainly used the language as genocide rather than systemic racism. So that, I think, is a deliberate legal choice. This report is a result of the Indian Residential School Agreement, the largest class action settlement in Canadian history, which was implemented in 2007. One of the elements of the agreement was the establishment of this Truth and Reconciliation Commission of Canada to sort of facilitate reconciliation among former students from the residential schools, although I am hesitant to refer to them as schools. I don't think generally schools have designs for graveyards next to them. Their families, their communities, and all Canadians. So out of this report, there were 94 calls to action, 7 of which relate directly to healthcare and healthcare services. The Yellowhead Institute recently sort of did a survey of how well those 94 calls to action are being implemented. It looks like we're actually rolling back. So I think the number was from 21, and it seems we're moving backwards to 19. So there still is much work to be done to see the implementation of these calls to action. Next, you'll see in 2016, First Peoples, second class treatment, the role of racism in health and well-being of Indigenous people in Canada, which was produced by Dr. Billy Allen, as well as Dr. Janet Smiley from the Well Living House in partnership with the Wellesley Institute. The report really clearly highlights that Indigenous people experience the worst health outcomes of any population group in Canada, and underscoring the urgency and the importance of understanding and addressing racism as a determinant of health, and particularly for Indigenous people. In 2019, you see Reclaiming Power in Place, the final report of the National Inquiry into Missing and Murdered Indigenous Women and Girls. And the final report reveals that the persistent and deliberate human and Indigenous rights violations and abuses are rooted in the causes behind Canada's staggering violence against Indigenous women, girls, Two-Spirit, and gender diverse people. So this is a 2-part volume. I am orienting you to these reports. If you're not familiar, I would recommend taking a look. They give you the details of sort of the impact, the widespread impact. So all of this sort of to set the context, right? We have sort of this historical relationship between our nations and the Canadian government. And so what happens in a response is you start to see in the Canadian context that the state starts to mobilize actors that actually, in the name of public health, but a lot of these state actors for many Indigenous people we're familiar with sort of these state actors and not in a good way. So for many people, this was experienced in our communities, was experienced as a form of social control rather than something that would protect us. So you start to see these state actors mobilize in the name of public health. You start to see things like the police start to enforce curfews for people not sheltering in place. So that's restricted movement, and it's very familiar to people in our communities. So you have this sort of tension with the state sort of wanting to use these familiar social actors to enact infection control, but who have these antagonistic and deeply troubling relationships with our community. So I want to talk, I've set the context, but I want to actually show you something that emerged as a result, and that sort of, to me, really celebrates the ability for a community to respond. I think we hear enough of the stories about the disease, the mortality rates in our communities. So I actually want to, and I don't think we get to hear enough of this, so I want to celebrate this effort. So what I'm showing you here is a response by community for community. The argument here is that community-led care is really the key, because no matter how well designed a health system and programming is, there will always be segments of the population not served or not served well. Meeting people where they are, mentally, physically, spiritually, and emotionally, centering empowerment and patient self-determination, modeling healthy relationships, providing access to culturally relevant supports, and harnessing the problem solving of the community is fundamental to shift the trend in adverse health outcomes, I would argue. But what does that look like in practice? I'm saying these things and they can feel very, very abstract. So community-led responses to COVID can feel a little bit abstract. So I do want to ground us in this real world example. What I'm showing you here is you see the logo on the left of Adoje Mino Nasewanong, which was for community by community opened COVID-19 clinic here in Toronto. Adoje Mino Nasewanong is comprehensive COVID response programming. And I should clarify, Adoje Mino Nasewanong means place of healthy breathing in Anishinaabe Moan. So you see at the bottom, 4 logos. These were the core group of partners that came together. Name Res, which is a transitional home and programming for Native men, as well as 7th generation midwives in Toronto, which is an Indigenous birthing clinic and offers wraparound care, as well as the Well Living House, which is an Indigenous-led research center. So knowing these histories and knowing and watching the state respond and how they mobilized, community partners got together really quickly and knew exactly that they needed to triage and put some programming in place that would provide some culturally safe integrated care, or we were going to see infection rates skyrocket. So the place of healthy breathing opened its doors on October 16th, 2020. It initially started as a testing clinic, only to evolve into a vaccine clinic that offers comprehensive service that now include in-community testing, personable communication results. So having somebody actually call you and explain things to you in a way that's understandable, case management, Indigenous-led contact tracing, vaccine education in clinics, outreach and testing, outreach and vaccination, outreach support, so mental health support. We know that isolation and food insecurity has been really challenging for many people in our community. They also offer clinical support and follow-up, as well as culturally safe communication. So I'm holding up this example because at Adoje, the professional practice is centered on strong community partnerships. So you see these 3 actors at the bottom who've been working in community and are from community, could come together and rapidly respond because they know who the community is. They didn't have to speculate on what the needs were. There was already a baseline there, as opposed to, I think, programs designed from outside of the community don't necessarily have a pulse on what the needs of the community are. And so it causes lag or tension when they're trying to design. It's worth spending a little bit of time talking about its governance structure, because I think it's illuminating in why community responses are so effective. So if you kind of draw your attention to the turtle, you'll start to see that's a model of the program and the governance structure. And that's graphic done by Lisa Bovin, a Dene artist and a PhD student at U of T's School of Medicine. So you see at the center, you'll find First Nations, Inuit, and Métis individuals, families, and community. All of the supports wrap around and center the patient and the family and the community. And then you start to see the Indigenous space. So it's community, individual, community, family first. The services are designed to support those relationships and those networks. And then you start to see the clinical spaces imagined to wrap around and offer those supports. And then at the very outer ring, actually what you see is a Doge's governance partners and reference groups. So to give you some insight, in order to do something rapid, the core partners listed at the bottom, which are in charge of overseeing the daily operations at the clinic, as well as the clinical programming, tap into a broader network of service providers, community-based service providers and leaders that serve our communities across the GTA to come together to help sort of build corridors of care across agencies, as well as help steer the project. So this larger network, relational network, sort of acted as a reference group to sort of drive and steer. So this is but one of many examples of Indigenous ingenuity in times of pandemics, where we have very little, but we get a lot done and take care of many, many people. I could list a few others. I think Anishinaabe Health is a very trusted partner. Very quickly, they were got an RV and were doing vaccines around the city, going door to door, going into places where people are precariously housed. So really knowing where our people are and knowing who they are and knowing what their needs are allow us to respond quickly. The Call Auntie hotline, which is a hotline that's set up to support new families in whatever needs they might need. So there's clinicians that work at that line, outreach workers that's connected to 7th generation midwives in Toronto. They quickly pivoted to into the space of providing COVID resources and connecting people to different agencies across the city. And again, we have Indigenous harm reduction, which is Indigenous on the ground harm reduction initiative that supports people to safely use or minimize harm associated with using illicit substances. So all this to say that, yes, the numbers are not great. There's a lot of challenges and barriers, but our community knows how to take care of each other. And so this points very much to Dr. Yearby's framework that actually justice health framework is important, because you have to understand the historical context and you have to understand the broader relationships and power dynamics at play. You can't just design a service and expect that people can access it or that it's the right fits their needs. So I'm just going to close off with saying that advancing First Nation, Inuit, and Métis health and wellness, using this sort of health justice framework, must respect that First Nations, Inuit, and Métis people are rights holders. We're not stakeholders. So we are in a relationship with the Canadian state, and it's meant to be nation to nation. So we're sovereign nations, and that can cause complications around health planning, particularly when you have potentially four nations or four governments in one jurisdiction operating. The second point is Indigenous data sovereignty is really important. So nothing for us without us. Dr. Yearby very carefully pointed out the gaps in data. So data about our communities are often not collected right or coded properly. And what this means is that that data is then used to leverage funding for health planning and programming. So if we are not represented or counted accurately, that also means that we're not getting the right resources to people. So the data matters. And that First Nations, Inuit, and Métis people need to have self-determination across the healthcare system. Because of the colonial settler history and sets of relations, it's really important that people from our communities, when they come into institutional spaces, that they're allowed to operate from a self-determined way. So that's sort of some of the key principles. I'm sure there are many, many more. And I just want to leave you with these resources. So if you're curious to learn more about sort of what the Indigenous experience is like when accessing service in the GTA, you can look at Our Health Counts Toronto. I've listed here a reference to their project overview and methods. This will be a comprehensive study that focuses on Indigenous experience, but it also has strength-based metrics. So also is able to capture that despite these incredible barriers, people are thriving and being able to bring creative solutions to problem solve. And then the second report, which is scheduled to be released on February 2nd or 24th, is What We Heard, Indigenous People in COVID-19. So this is run by Angela Mashford Pringle. Dr. Pringle runs a cultural safety lab at Waakabanus Bryce, the Public School of Health. So if you want to hear what community experience is, that would probably be a really great report. That was done in partnership with Public Health Canada. And I would also add that I believe, don't quote me on this, that the Our Health Counts Toronto has actually expanded to do some data linkages around COVID-19 infection rates in the GTA. So you may be able to, for people that are a bit data wonky, might be able to tuck in there and get a more comprehensive picture. So thank you so much for your time.
Thank you very much, Ruqaiijah and Emily, for really complimentary presentations highlighting the serious problems, but at the same time showing also how there can be community responses that offer at least a partial solution. So we'll open it up for questions now, and as those who attend this seminar often know, I will first allow some students to ask questions. If people have questions, they can put up their hand, also write something in the chat box. I'll keep an eye out for questions, but I'll start with some questions from students. So without waiting for questions from the audience, Alice Sao, can you start with your question, please?
Sure. Hi. I was wondering if the speakers could speak a little more about how we can improve representation as it relates to improving health outcomes. Are you thinking of like policies or just different regulations? I'd love to pick your brains on that. Thank you.
Yes, Ruqaiijah, maybe start and then we can go to Emily. Okay.
I can start, even though I don't want to start on answering all questions, definitely, because I want to respect my colleague. I think for me, one of the ways is to ensure that you get people from diverse backgrounds making the decisions. So it's not all just academics, that it is always including people who are impacted by those decisions. But I also want to make sure is that we don't tokenize people and assume, oh, if we have, one person of color and one Indigenous person, that they're going to be able to talk and identify all the problems that we have, right? We do need diverse representation, but just having one person, as was mentioned, is not enough, right? We have to change the structure of it. And so even going about the ways, going about making decisions differently would be great, right? And so as was mentioned, right, the lockdown procedures and people policing, it's a very different perspective of that from different communities, and just thinking about that to begin with. The last thing I would say is that at least for the US, we think that we pass a law and that would help and that we're done, and it's not, right? That we always have to continuously evaluate, get feedback, see if we're doing things correctly, see if the people who we're trying to help are actually being helped, and if not, are there ways that we can change?
Yeah, thank you for that question. And I think, Dr. Yearby, if I can build on what you're saying, this idea of co-led or community decision-making processes, which really that reference group and that outer ring of that beautiful logo for Doje Mino Nisewanong represents, right? It's this accountability structure actually. So when we're working with our communities, we have to be accountable to our communities, but we also have to be accountable to each other, right? So when you're situated in and you're working alongside of in a leadership position. So I think, one way is to foster co-leadership models, which is a very, I would say, centered in Indigenous pedagogies, community-centered, right? Like putting the community at the center and then building everything around rather than forcing people into the box. And then the second thing about representation, I think about this a lot, and I think about this as somebody that's white coded, working in institutions. We talk a lot about, on our team anyways, when we go to meet our colleagues, non-Indigenous colleagues at research ethics boards or at other tables, and many of them are our allies, we try and actually always go, there always is two of us, because we are trying to also work to counter this idea that one person can speak for three nations, or that the experience for us is all the same. Like the thing that binds us together is the colonial experience. However, we're all located in that differently. So I think, we spend a lot of time doing a lot of education to support learners to sort of understand what that means. But it's a tricky one. I think accountability, I think the more that institutions can be accountable to how they partner and become places that are desirable to operate and work and partner with, we'll see an expansion in representation. I agree. I don't think it's enough just to recruit because you want an equity, diversity, and inclusion quota because there's money attached to it. You have to see institutions have to make some transformative change to become desirable. So I think there's a lot of work on the institutional side.
Danny Garris, please.
Yeah, hi. First of all, I wanted to say thank you so much for this talk. I really learned a lot. My question is related to one of the pages in the report discussed how the average life expectancy for Black people is much lower than white people, and it's something I would have never considered in Canada when the rollout of vaccines was based on age eligibility dropping every few weeks. So I was wondering if Professor Yearby, you can speak to what we can do in the future if we limit the rollout plan just to essential workers and hotspots, or if we also, it's a strange idea, but can we limit vaccine allocation to specific age groups of specific racialized groups, and how the public would perceive something like that?
Yeah, so thank you for that question. And so, we definitely have that issue in the US as well. And to me, if we're going to do a very targeted, focused, effective public health response, it would be to track where the outbreaks are, right? And so be able to have that data and yes, give the vaccines to where the outbreaks are, and also then give it based on age. Now, for me, what would have been interesting is to see the overlap, right? Because I think a lot of the outbreaks were in nursing homes, impacting nursing home workers, as well as the elderly and those who were disabled. So I think you're going to get some of those same groups. But I say being able to go to hotspots would have helped, right? So able to go to meat and poultry processing plants would have helped all of us because it would have stopped the spread to the community. Doing it in nursing homes would have stopped the spread in community. Doing it for people who are actually going into people's homes as we're locked down would have stopped the spread, right? And so to me, if you could logically say, we understand we have limited resources, we know we have certain groups that are more vulnerable, we're going to hit with them, as well as the people who they may come into contact with as essential workers, and go down that use those two groups, then we would have gotten to everybody, and we probably would have prevented some major outbreaks. But just being honest about it, right? And why we're doing it, and that it's going to help everybody in the long run.
Thank you.
Thank you. Emily, you want to add something, or we go to the next question?
Yeah, I think I can just build on that quickly. Like, I think leveraging pre-existing data where we know what the vulnerabilities are. And so it's about creating those data linkages, and then actually really understanding who the community leaders are, right? And getting, because you can prioritize, but if you're doing them in institutional settings, you might not see the outreach. So really leveraging, like we have the data, we know who the community leaders are. And, there was, I think, some public scrimmage because First Nations, Inuit, and Métis we were a prioritized population, but even because our average lifespan's shorter, we had to sort of fight to actually have the average age lowered to actually be reflective of what the lived experience is. So, I think it's really, I always go back to the place that, really recognizing where the expertise are. People know how to get stuff to each other. So it's just kind of, that approach.
Thank you.
Okay. Safawarsi.
Hi. Yes, sorry to sort of derail the conversation, but I was more interested in, so currently we're having a discussion about the myths and mistrust right now in vaccination and how a lot of work has to be done in public information. And I was wondering how that fits into the discussion we're having now about the health justice model.
Yes, so I would add to that, maybe to that particular question, whether the two speakers have anything to say about the traditional mistrust that has existed in some communities due to past abuses in the healthcare system and lack of access to adequate care, colonial practices in research, and so on. Ruqaiijah, maybe starting, okay?
I'm gonna let Emily start this time, and then I'm gonna
Okay.
back her up. Yep.
Well, we'll mix it up. Thank you so much for that question. It's actually a really important question. Communicate knowledge translation practices are key for building trust and actually getting information out correctly. Like, we worked at Women's College Hospital at the Center for Wise Practices. We did a project called Sharing Medicine Project, which was all about community-facing informational resources around COVID-19, vaccination, patient safety. And one of the things that we used was we actually made short documentaries where we brought together sometimes traditional knowledge keepers into conversation with clinical practitioners from our communities. So people that practice Western medicine, as well as community members, and we let them have a conversation, because what we really found was that people, it was good to sort of acknowledge publicly that there was a lot of uncertainty and show people actually going through their decision-making processes. So modeling decision-making processes and supporting people to see that, like, the questions they're having, they don't need to be alienated with. Other people are having the questions. And I think that was a really big, we saw a lot of traction. We saw people reach out across Canada at health service provision organizations and use those tools. We got a lot of feedback. So again, I think it matters who tells the story and how the story is told. And then with the vaccine, we talk about vaccine hesitancy a lot, but we also see, the trucker convoy that's going on right now. So, like, these patterns about, who we think mistrusts institutions and why they mistrust institutions, they're very different reasons, right? And to your point, Trudeau, like, we have to have a very real conversation that institutions like Sick Kids Hospital was involved in the residential school system, right? So people my age could have been in the residential school system. So we're not talking about colonialism as an artifact. It's a system of thinking and it's a mode of relating, right? It's not a historical event. So it's quite a complex question. We found that when we showed people in conversation with each other, talking about the stresses and the struggles they were having around their decision-making, that and modeling that for people was really an effective communication strategy.
And I love that. Going back to your point, Emily, what you said about how we view people differently, right? So a very different discussion about vaccine hesitancy among people of color versus the rights of whites to not want to take vaccines, and not only not take vaccines, but then to roll back vaccine mandates for all of us, which are protective, right? And so I just want to put that out there, is that even that can be racialized in a sense. So in the chat, I put some links to some papers on health justice, including a blog series that expands this idea of health justice. In the paper, we just focused on really trying to get the government to understand it needs to give away some of its power and stop taking away people's powers and rights. And blaming people. But since then, we have worked to expand it to incorporate this notion of truth and reconciliation and ways that the government, the healthcare institutions need to be responsible for admitting the harm that they caused. For working with people to overcome it. And then the last part, as you can see, I'm at the Institute for Healing Justice, is also to provide support for people to heal from their trauma in the time frame that they're willing to move forward, right? Because as lots of people were talking about vaccine hesitancy, those same essential workers were being allowed to die, not having masks, being forced to go to work. And now you're saying to them, oh, but we want you to take this vaccine, right? And if you need to take time off of work to get the vaccine, we're not going to allow you to. And if you need to take time off from work because maybe you're feeling a little under the weather because of the vaccine, we're not going to allow you to. So really understanding why people are in the place that they are and providing supports to listen to them and for them to heal.
Thank you very much. What I'll do now is, because we're coming close to the end, I'll ask Safa Bajwa, Kim Goebbels, and Mary Fiedler to say their questions, and then we can see if there is some commonality in the responses that the two speakers can provide. If we still have time over, there are more questions of students, but I will share it with the two speakers, and they can also get back to some of the students in person. There is also an interesting question by Shannon in the chat box. So maybe that question can as well be considered. But so we'll have to see what the speakers can respond. So starting with Safa Bajwa, and then we go to Kim, Marie, and Shannon. Okay.
Hi, thank you both for your presentations. Part of my question was already addressed in part in the discussion about the discourse surrounding the term universal healthcare in Canada. But I also wanted to ask, in Professor Yearby's paper, you did mention that often implicit bias exists amongst healthcare professionals. And so I was wondering what you thought of the possibility of policymakers focusing some of their attention on addressing those concerns, while also addressing access to healthcare and what those policies might look like.
Okay, Kim.
Okay, my question is a little bit specific to the agriculture sector. I'm from a farming community, and my family had migrant workers, and I realized that the migrant worker situation is quite different in that it involves like the housing element. And so in our town, there was like massive fights over okay, you're making me as a farmer spend like $1 million to build like 3 or 4 more what they call bunkhouses that are only going to be used during the COVID pandemic. So I was just wondering if you can talk about how you think the burden of some of these expenses would best be shared. Because at the same time, like agriculture workers could take that $1 million, invest in automation, and then wipe out jobs for migrant workers altogether. So that was kind of mine.
Okay. Very important question as well, Marie.
My question, Dr. Yearby focused on it a little bit, but so also Professor Lemons, I apologize. This is not the question that I submitted. This is a question that came up during the presentation. You both identified issues with, the carceral way we approach public health. So the fact that we have these mandates, but, it's not everybody who's being punitively like engaged with those mandates. It's usually very marginalized people and people who already have like fraught relationships with state actors. And so I'm wondering, given that context, whether you still think, carceral mandates are necessary and appropriate, and how you think we should like negotiate those really real tensions.
Very good. So Shannon, the last question, and then we'll go to the two speakers to see what they can respond of all these very important issues. So Shannon G, which was in the chat box. I'll simply read it for the audience. So I'm wondering if you have thoughts on the arguments that some Black scholars have shared that collecting race-based data can have harmful impacts on racialized communities. For example, companies use race-based data to inform predictive algorithms used by health systems planners. This is of particular concern because it has been repeatedly demonstrated that algorithms reinforce bias. So very different questions. I don't know if you will be able to, both of you, to address some of these.
I can jump in really quick and hopefully answer the questions that were to me. If not, feel free to email me. So in terms of the implicit bias around healthcare providers, definitely. And Dana Bowen Matthews, who has a wonderful book out called Just Health. Sorry, I was grabbing it. Just Health, Structural Racism to Heal America, often talks about this, is that one would say we've been researching this for about 30 years and people know about it. So it's no longer implicit because we are quite clear about our explicit bias against each other. And let me be clear that research has shown that most people have an anti-Black bias in the United States, including Black people. So we need lots of education to overcome this, but we also need to apply standards that will hold people accountable and educate them quite often about it. And none of that is required for licensure of healthcare providers. They're not held. The law about anti-discrimination and healthcare is not applied to healthcare providers. So that would be a good start. But if you have more questions, let me know. Going to the agricultural workers and the housing, I think that smaller businesses should be provided with support for housing and to be able to keep their workers safe. And so do I say that for JBS or Tyson that made billions of dollars? No, but I say that for an individual farmer, yes, that there are ways that the government was supposed to be supporting those individuals in terms of either payments, tax benefits, helping them gain access to not hospitals, but hotels that were closed that they were putting people in. So yes, I think the government should do that because to me, that's sort of what our tax dollars are for, instead of giving it the money to the people who are making billions of dollars. So I think there's a way that we can do it to support the farmers and the workers. to keep that going. In terms of mandates, I think that we can do mandates, but it's the ways that we do it. And so New York was a beautiful example of this. The police were passing out masks in the predominantly white neighborhoods and educating and meeting with people. And in the Black neighborhoods, they were arresting people, right? And so there's a way that you can support people in trying to ensure that they're healthy, but do it not so in a way that just always criminalizes people. And I'll just say this, I mean, come on, you're gonna arrest a homeless person for not wearing a mask. That makes no sense. They're homeless. They do not have the money to buy a mask, but you're going to let all the tourists just walk through and not have a mask. And then finally, race-based data. I wrote an article called Race-Based Medicine, Colorblind Disease, how race and medicine harms us all. So I love, and I wrote down Emily's description about racialized conditions. And that's what I really think we need to do, is really track conditions and the discrimination that leads to the problem, and not race, because then we make it a biological context. So I'll stop there.
I can add on a little bit. that was kind of spectacular, the breath you just did. So I'm a little bit in awe. I think this idea of healthcare bias is really interesting, right? So again, we know this, it's well documented. So it actually, within the Canadian context, for health researchers, for hospitals that are taking that public funding, there's those 7 calls to action that we're all accountable for, holding these institutions accountable for implementing, right? Including making sure that their hospital is practicing in a culturally safe way. That is the institution's responsibility. I mean, a large part of what we do at the center is partner with practitioners to support them to treat our communities well, right? And I want to say, you know, we talk a lot about cultural safety, but also from years of sort of standing next to practitioners, there's a real commitment not to be racist in their practice, of course, but many physicians or healthcare practitioners struggle to identify what those behaviors look like. So we talk about cultural safety, but I think we also need to flip the script a little bit and say, actually, this is what racism looks like in point of care. It's offering below quality of care. You're not taking an incomplete medical history. You are so really supporting our physicians and practitioners to understand what those behaviors look like, I think is a really important intervention, and then holding those institutions accountable, because if they're taking federal money, they're implicated in the reconciliation process. And then the last point I'll go to is just around data. I love this question of data. I always love this question of data. I certainly can't speak too much about data collection practices in the States, or I don't want to speak for my Black colleagues, but I do want to talk about what happens in Canada, which is the OCAP principle, which is ownership control on Indigenous data sovereignty. And that doesn't mean that, you know, we get the data afterwards. We determine how that data is collected and coded and then translated and circulated, because we understand that colonialism is built into coding practices too. It's how we're counted, how we're looked at, how we're measured, how we're interpreted, and then how that story circulates. So there are some really great data justice frameworks out there, and some really great initiatives. For people that are not familiar, I would look at OCAP as a place to start about ownership and control, and that's First Nation data sovereignty. So thanks.
On that note, let me conclude by doing something that I normally would have started with, but in the speed of getting the seminar going, I wanted to acknowledge actually that many of us, certainly myself, are speaking on traditional land of the Huron-Wendat, the Seneca, the Mississaugas of the Credit. And so it's more than appropriate to conclude certainly with this, to thank the Indigenous people from which we are speaking here, and in connection with that, to thank our presenters for a very enriching and very interesting discussion, to thank the audience, the students, and the other participants for having asked wonderful questions. And please join me in thanking everyone.